Picture this. An 84-year-old woman goes into the hospital for just a routine hip surgery. She's totally sharp. She lives independently and does the Sunday crossword every single week.
Right, a very familiar baseline for a lot of patients.
Exactly. But then 2 days after her surgery, she completely doesn't know her own name. She's frantically picking at her bed sheets, and she's terrified, like insisting she's trapped in a strange house.
And her family is standing right there at the foot of the bed, absolutely panicking.
Yeah. Their immediate thought is always, this is it. We lost her. It's Alzheimer's. But guess the question for today's deep dive is, what if it's not?
What if her brain isn't experiencing this permanent, irreversible decline, but it's actually just in the middle of a totally reversible acute metabolic crash?
Welcome to today's deep dive. We are tackling a massive, incredibly common mix-up in medicine, which is untangling delirium from dementia.
Yeah, and that panic from the family in your example, healthcare providers see that constantly. It stems from this really dangerous habit we have of taking two completely different neurological conditions and, well, just throwing them into the same bucket called confusion.
Which is such a disservice to the patient.
Yeah.
I mean, mixing these two up isn't just some vocabulary error. It leads to massive diagnostic blunders that cause real harm.
It absolutely does every single day.
So knowing the difference here is literally a life-saving skill. Whether you are a nursing student doing rounds or a caregiver looking after an aging parent, or you just want to understand how the brain works under stress, this is incredibly high yield for you.
It really is. And to start, we should probably lay down some foundational mechanics, right?
Yeah, let's use the smartphone analogy from the sources, because I think that works perfectly.
Yeah.
How do we categorize dementia versus delirium using a phone?
Well, I love that analogy. If we use the smartphone model, dementia is basically a hardware issue.
Okay, so the physical parts of the phone.
Right. The battery is permanently degrading, the microchips are corroding over months and years. The physical structure of the brain itself is slowly failing.
And just to clarify, the sources note that the term dementia was actually retired from the psychiatric manual, the DSM-5, back in 2013, right?
Yeah, that's spot on. It was retired to reduce stigma. It's technically called major neurocognitive disorder now. But honestly, at the bedside, dementia is still the word everyone uses to describe that chronic hardware degradation.
Got it. So if dementia is the physical phone breaking down, where does delirium fit into that?
Delirium is a software crash. The hardware might be, somewhat weathered from age, but suddenly a rogue app starts taking up 100% of the RAM.
Oh, like a bad medication or an infection.
Exactly, or even severe dehydration. The operating system just totally freezes. Delirium is a flashing red alarm indicating a medical emergency.
So the brain is effectively screaming that it does not have the resources to function in that exact moment.
Yeah, it doesn't have the metabolic or physiological fuel, and it manifests as this acute, wildly fluctuating disturbance in thinking.
It's so fascinating. And history actually gives us a really great window into how long we've been trying to articulate this software crash. The etymology in the sources paints such a vivid picture.
It really does, especially when you look at the sheer age of the word delirium. I mean, it is older than dementia by nearly 2,000 years.
2,000 years, that's wild.
Yeah, it comes from the Latin word delirare, and literally translated, that means to go off the furrow or off the plowed track.
Oh, I love that. So the prefix de means away, and lira means furrow. It's an agricultural metaphor.
Exactly, it's an ancient farming reference.
So if delirium is the mind wandering off the plowed track because of a temporary storm, like that infection or a new drug, then dementia, which comes from the Latin dement, meaning out of one's mind, is the track itself slowly fading away.
That is a beautiful way to visualize it. And that agricultural visual holds up really well for centuries. Starting with the Roman Encyclopedia Celsus in the 1st century AD, delirium was just a descriptive word.
Like it wasn't an official diagnosis yet.
Right, not at all. It was merely a way to describe at the bedside the feverish ravings of someone who was dying or just severely ill.
So it was just viewed as a symptom of being really sick. And for a long time, the medical community didn't view senile dementia as a specific disease either, did
Yeah, they didn't. They just assumed if you got old, your brain naturally weathered away. That was the prevailing assumption for most of the 20th century. Old age just equaled cognitive decline.
Until 1906, right, when Alois Alzheimer completely shattered that belief.
Yes. He was a German psychiatrist, and he presented this incredible case of a woman named Auguste de Terre. She was only 51 years old.
Wait, 51? That completely rules out the normal aging hypothesis right out of the gate.
Completely. She suffered from progressive memory loss, intense paranoia, and eventually her language just totally disintegrated.
Wow. And when she passed away, he actually examined her brain tissue, right?
He did during an autopsy, and he found these abnormal clumps of protein, which we now know as amyloid plaques, and tangled bundles of fibers called neurofibrillary tangles.
So he essentially proved that her cognitive decline wasn't just the natural passage of time.
Right. It was a discrete neurodegenerative disease that was actively destroying the brain's tissue.
Okay, so that perfectly establishes the hardware failure. The physical track is literally being destroyed by plaques and tangles.
Yeah.
But how did we finally get a biological grasp on the software crash, on Delirium?
Well, that shift didn't actually happen until 1959. Two psychiatrists, George Engel and John Romano, published a paper that completely reframed it.
What did they do differently?
They called delirium a measurable state of acute brain failure. They actually hooked delirious patients up to an EEG, which measures the electrical activity of the brain.
Oh, so they could physically see it happening.
Yeah, exactly. They could literally watch the brainwaves slow down in real time. It showed the brain's metabolism was failing, like it just didn't have the energy to fire its neurons properly.
And the most important part, according to the sources, is that they proved this generalized disturbance was reversible, provided you found and treated the underlying cause.
Yes, the reversibility was the key finding there.
Which is great historical context. But if I'm a nurse on a busy ward today, I don't exactly have time to look at brain tissue under a microscope, and I definitely might not have an EEG machine handy.
No, you definitely won't in most standard rooms.
So how do you actually tell the difference between a fading track and a temporary storm just by talking to the patient?
Well, you rely on the four bedside axes of distinction: onset speed, the course over a day, attention, and reversibility. Let's look at onset first.
Okay, onset. Delirium happens fast, right? Like hours to a few days, whereas dementia takes months to years.
Spot on. So if a family brings someone into the ER and says, Grandpa was completely fine at breakfast, playing Sudoku, but by dinner he didn't know his own name, that speed is your biggest red flag.
That speed screams software crash.
Exactly. The trajectory tells the whole story. The second axis is the course within a single day. Delirium fluctuates wildly.
Meaning they could seem fine 1 minute and totally out of it the next.
Yeah. A patient might be totally lucid, holding a perfectly normal conversation with you at 10 a.m., but by 4 p.m., they are profoundly disoriented, maybe hallucinating or severely agitated.
And dementia doesn't do that.
No, dementia is relatively stable hour to hour. A person with Alzheimer's is going to struggle to remember their granddaughter's name just as much in the morning as they do at night.
Okay, let's dig into the third axis, because the sources call attention the single best bedside discriminator. And I want to make sure I really understand the mechanics of this.
Sure, it's crucial to grasp.
So if I ask an elderly patient to spell the word world backward, they don't know what day of the week it is, but they can sit there and focus their mind to spell DLROW for me. That points to dementia.
Yes, that's exactly right.
But if they get distracted halfway through because, I don't know, a nurse walks by in the hallway, that points to delirium.
You've hit on the absolute crux of it. In early to moderate dementia, the brain's underlying energy supply is actually still somewhat intact.
So they have the power to focus.
Right, attention is relatively preserved. The patient can sustain focus on your request. They just might not remember the conversation 5 minutes later because the memory storage hardware is broken.
But in delirium, the attention mechanism itself is what's shattered.
Exactly. The brain is in a metabolic crisis, so it literally cannot hold a thought or filter out background noise.
So if you ask them to recite the month of the year backward, they start, get distracted by a beep from a heart monitor, and just lose the thread entirely.
Yeah, it's a mechanical inability to maintain focus. Which leads us to the fourth axis, which is reversibility and cause.
Right. We know dementia is caused by things like those Alzheimer's plaques you mentioned.
Yes, or vascular infarcts, which are basically microscopic strokes that cut off blood supply to tiny regions of the brain over time.
Oh, so that creates like a stepwise decline.
Right. And another common cause is Lewy body dementia, where abnormal protein clumps disrupt neurotransmitters. That causes cognitive decline paired with Parkinson's-like physical tremors.
And all of these are ongoing neurodegenerations. Medicine can maybe slow them down, but we can't reverse them currently.
Exactly. Now contrast that with delirium, which is driven by a fixable precipitant.
This is the part I really want to understand the how on. How does a simple urinary tract infection, a UTI, cause acute brain failure? It sounds crazy.
It is a fascinating and honestly terrifying cascade. When a younger, healthy person gets a UTI, their immune system handles it locally in the bladder.
Just a localized battle.
Right. But in a frail older adult, that local infection triggers a massive systemic alarm. The immune system just floods the body with inflammatory proteins called cytokines.
And those cytokines travel up to the brain.
They circulate in the blood, yes. And because an older brain's defenses, like the blood-brain barrier, are often weakened, those inflammatory markers actually breach the barrier.
Oh, wow. So the infection literally invades the brain's environment.
It does. And once inside, those cytokines trigger the brain's own immune defenders, the microglial cells, to just go into absolute overdrive.
So you get severe neuroinflammation.
Exactly. And that inflammation throws off the synthesis of key neurotransmitters, especially acetylcholine, which is vital for attention and awareness.
So a simple bladder infection launches a chemical attack that unplugs the brain's communication network.
That is exactly what happens. But if you give antibiotics and clear the UTI, the cytokine storm stops and the delirium usually resolves.
Applying this to the hip fracture case from the beginning, it makes total sense now. An 84-year-old has major surgery. The physical trauma, the anesthesia, the painkillers, it's a massive storm.
Right. All of those things launch a huge inflammatory and chemical storm in her body.
So 2 days later, her attention is broken. She's picking at the sheets. That is textbook delirium.
And it is incredibly common in frail, elderly patients after surgery or in the ICU.
But, the hip fracture example sounds sort of obvious because the patient is visibly agitated. She's vocal. She's moving.
Yeah, that's what people expect to see.
Right. When we hear delirium, we immediately picture someone thrashing around, pulling out their 5E lines, shouting, kind of like delirium tremens from severe alcohol withdrawal.
You're describing the hyperactive subtype of delirium. It's the dramatic, cinematic version everyone pictures in their head.
But the sources say the reality on the ground is very different.
Very different. The most common presentation in older hospitalized patients is actually the hypoactive subtype, and it is the most frequently missed by doctors and nurses.
Hypoactive meaning underactive. What did that actually look like for the person just sitting in the hospital bed?
Well, these patients are quiet, withdrawn, lethargic, and apathetic. They might just sleep all day or stare blankly at the wall.
And if you talk to them?
They might just answer questions with single syllables. The danger is that a quiet patient doesn't demand attention the way a shouting, agitated patient does.
The squeaky wheel gets the grease, especially in a busy hospital.
Exactly. Studies repeatedly show the vast majority of hypoactive delirium cases go completely unrecognized at the bedside.
That is just a silent catastrophe. Inside that quiet patient, the brain is still in a state of acute failure, right? The cytokine storm is still raging.
It's still a medical emergency, but nobody is noticing.
Which raises a really tricky scenario for you if you're working in a clinic. What happens when a patient has both?
Yeah.
Let's say someone who already has Alzheimer's comes into the hospital for a minor procedure and develops hypoactive delirium on top of it.
You're touching on delirium superimposed on dementia, or DSD. This is a massive trap for healthcare providers.
That's so.
When a patient with pre-existing dementia has an acute worsening of their mental state, maybe they stop talking entirely. Families and clinicians alike often throw up their hands and assume, well, the dementia is just progressing.
They see the cognitive decline and just blame the chronic disease they already know is there.
Exactly. It's a huge blind spot.
And if you are listening to this, you can immediately see the danger. Because someone already has an Alzheimer's diagnosis, a totally curable urinary tract infection gets ignored.
Or a toxic reaction to a new sleeping pill gets missed.
Right. It just gets written off as inevitable decline.
Failure to catch DSD means a treatable, life-threatening insult goes entirely unaddressed. It is one of the most consequential diagnostic errors in geriatric medicine.
Before we move on to how we actually fix this, the sources mention a couple of neighboring terms that I want to clear up for anyone navigating this space. We hear the term sundowning a lot.
Right, sundowning is very common to hear.
And also something called pseudodementia. Let's start with sundowning. What is that exactly?
Well, sundowning is just a descriptive term for patients who become more confused, anxious, or agitated in the late afternoon and evening as the sun goes down.
So is it its own specific disease?
No, clinically, what gets casually labeled as sundowning is very often just undetected delirium layered on top of dementia. It's usually triggered by fatigue or poor lighting in the evening. It's not a distinct disease.
Okay, that makes sense. What about pseudodementia? Because that sounds like a fake hardware crash.
In a way, it kind of is. Pseudodementia refers to severe depression that basically mimics cognitive decline.
Oh, really? Depression can do that?
Yeah. The patient has slowed thinking, poor concentration, they complain about their memory. It looks remarkably like dementia.
Yeah.
But the mechanism is mood-based, not structural.
So if you treat the depression, does their memory come back?
Yes. Once you treat the underlying depression with therapy or medication, the cognitive issues clear up completely.
Wow. It's staggering how many things wear the disguise of dementia. So realizing that a quiet, withdrawn patient might actually be in a state of acute brain failure is sobering.
It definitely shifts your perspective.
But if there is neuroinflammation happening, how do we stop it? Historically, medicine took a pretty aggressive approach to the agitated, hyperactive patients.
Right. Yeah, for decades, the standard hospital practice was straightforward. If a patient was delirious and pulling out their tubes, you just gave them an antipsychotic or a heavy sedative, typically a drug called haloperidol.
Which, on the surface feels sort of logical to a stressed out medical team. The brain is hyperactive, the patient is a danger to themselves, so you give them a drug to calm the brain down.
But did it actually calm the brain down or just the body?
Oh, right. The sources highlight this massive 2018 trial that finally answered that.
Yes, the Mind USA trial, published in the New England Journal of Medicine, they tested haloperidol and another antipsychotic, ziprasidone, against a placebo in ICU patients suffering from delirium.
And the results were a genuine bombshell, right?
Absolutely. The antipsychotics did absolutely nothing to reduce the number of days patients spent delirious. They didn't shorten the ICU stay, and they didn't improve mortality.
So if you're listening to this and you've ever had a relative given sedatives in the ICU to calm them down, this has to be a terrifying revelation. We weren't treating the brain at all.
No, we were just treating the symptom, the agitation, to make the patient manageable for the staff.
Because haloperidol just blocks dopamine receptors.
Exactly. That stops the thrashing around. But it does absolutely zero to stop the inflammatory cytokines from a UTI or to reverse the metabolic starvation of the brain.
So the biological fire of the delirium just continued to rage on underneath the chemical restraint.
It did. It was just masking the failure.
That is a colossal medical failure. But it leads into an even bigger bombshell from the sources, one that completely reverses a long-held 20th century belief.
This is probably the most important shift in how we view delirium today.
Yeah, because we've been talking about delirium as a reversible state. The old logic was, fix the UTI, the delirium goes away, the software reboots, and the phone works perfectly again.
Right. No lasting harm. That was the old teaching. That delirium was a temporary detour with no lasting cognitive cost.
But that's not true anymore.
Not at all. Longitudinal research following patients after they leave the ICU or cardiac surgery has completely overturned that. Studies show that patients who experience a severe episode of delirium have a significantly higher risk of accelerated cognitive decline and subsequent dementia in the years following.
Wait, so it's not harmless once it clears. It doesn't just reveal a vulnerable brain. An episode of delirium actively injures the brain.
It does. It leaves a scar. Severe neuroinflammation causes collateral damage to neurons. It really blurs that once tidy line between acute and reversible on one side and chronic and progressive on the other.
So delirium might actually be a catalyst that accelerates long-term hardware degradation.
Exactly. It actively damages the hardware.
Which makes the stakes astronomically higher for you and your loved ones. If drugs don't fix it, and merely having an episode of delirium causes permanent brain injury, how do we stop it?
The ultimate solution is prevention. And this is where the pioneering work of geriatrician Dr. Sharon Inouye completely changed the landscape.
What did she do?
Well, in 1990, she recognized that you can't prevent what you can't measure. So she invented a screening tool called the CAM, the Confusion Assessment Method.
Okay, how does that actually work at the bedside? What are the nurses actually measuring?
It's a quick algorithm that takes under 5 minutes. A nurse evaluates 4 features. First, is there an acute onset or fluctuating course?
Basically checking the timeline.
Right. Second, is there inattention? Like, can the patient squeeze your hand every time they hear the letter A in a sequence of letters?
Ah, testing that mechanical focus.
Exactly. Third, is their thinking disorganized? Are their answers rambling or illogical? And fourth, is their level of consciousness altered? Are they hyper alert or lethargic?
And how many of those do they need to flag for delirium?
If a patient has the first 2 plus either of the last 2, they are flagged.
So it forces the medical team to actively check for that broken attention mechanism, catching even the quiet, hypoactive patients.
Exactly. And once you can measure it reliably, you can test ways to stop it. which Dr. Inoue did in 1999 with a landmark trial also published in the New England Journal of Medicine.
Did she test a new drug?
No, she didn't test cutting-edge pharmaceuticals at all. She tested a multi-component intervention that targeted basic environmental and physiological risk factors.
That makes sense. If the brain is starving for metabolic resources, you have to support its baseline needs. So what did this intervention actually look like in practice?
It was fundamental, rigorous nursing care. They put up large orientation boards so patients always knew the date and where they were.
Okay, keeping them grounded in reality.
Right. They aggressively minimized nighttime disruptions, clustering blood draws and turning down alarms to ensure uninterrupted sleep. They got patients out of bed and walking to promote blood flow.
And pushing fluids to prevent dehydration, I imagine.
Yes. And crucially, they gave patients back their reading glasses and hearing aids.
Let's pause on that last one. Why would not having reading glasses trigger acute brain failure?
Think about the mechanism of sensory deprivation. If an older patient is lying in a hospital bed without their glasses or hearing aids, the world is a blurry, muffled, terrifying place.
Oh, I hadn't thought of it like that.
The brain has to work overtime, exhausting its limited metabolic reserves just to interpret shadows and mumbles. By giving them their glasses, you instantly reduce the cognitive load.
You remove that stress on the operating system. Did it work? Did delirium rates actually drop?
Dramatically. The intervention group had a substantially reduced incidence of delirium. Dr. Inoue proved that this acute, life-threatening brain failure is highly preventable.
Not with drugs, but just by engineering an environment that supports the brain's fundamental needs.
Exactly. Basic human needs.
That is profound. And it brings us right back to you, the listener, and why untangling these terms empowers you. Let's rapidly synthesize what we've covered today.
Sounds good.
Delirium is a fast-acting software crash. It fluctuates wildly, it breaks a person's mechanical ability to pay attention, and it is always driven by an underlying medical cause, like an infection triggering neuroinflammation.
Right, whereas dementia is a slow hardware degradation. It takes months to years to develop. It remains relatively stable within a single day. It spares a person's attention in the early stages, and sadly, it has no cure.
We also learned that hypoactive delirium, the quiet, withdrawn patient, is the silent killer because it is so easy to ignore.
And if we lazily assume that a sudden cognitive decline in someone with Alzheimer's is just the dementia getting worse, we might be masking a life-threatening but completely treatable emergency.
The boundaries between these two conditions are porous. Delirium causes lasting damage, meaning preventing that acute brain failure is one of the most critical things a healthcare team or an advocating family member can do.
Absolutely.
Whether you are charting notes on a geriatric ward or advocating for your own parent in an overcrowded, chaotic ER, knowing the difference between a chronic brain disease and a reversible check engine light changes everything.
It changes the questions you ask the doctor. It changes how you observe your loved one.
It shifts you from a place of panic to a place of action.
It really equips you with the vocabulary to intervene when the medical system might be missing the subtle signs.
And I want to leave you with a final thought to mull over today. We learned that Dr. Inoue proved a state of acute brain-injuring delirium can often be prevented simply by giving a patient uninterrupted sleep, hydration, mobility, and their reading glasses.
Yeah, basic physiological support.
So if the lack of those basic fundamental human needs causes the brain to rapidly fail, are modern hospitals themselves fundamentally toxic to the aging brain?
That is a very heavy question.
Think about it. The constant beeping of monitors at 3 a.m., the sensory deprivation, the windowless rooms. If the very places we go to heal are actively inducing cognitive trauma, what would it look like to design a hospital that actually healed the mind instead of just the body?
It's a design challenge we desperately need to solve.
Something to think about. We'll catch you on the next deep dive.